Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arawa, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 439 of our pharmacotherapy series, which majors in prostate cancer. The first case reads, SJS is a 50-year-old African-American male who has never been screened for prostate cancer. He has no comorbidities, does not smoke, exercises regularly, and has a diet consisting mainly of red meat 4 to 5 times a week, with few vegetables and fruit. My first question to you reads, what are SJS's risk factors for prostate cancer? We will begin with his age. Risk factors are important in identifying those men who are most likely to develop prostate cancer, and also helps identify those who will most benefit from screening. Age is the most important factor, with over half of all cases occurring after the age of 65 and rarely occurs before 40 years of age. Median age at time of death is 80. Regarding his ethnicity, the risk for development of prostate cancer begins to increase after the age of 50 in white men and after age 40 in black men. In the United States, the highest risk is in African Americans with lower survival rates. Prostate cancer also has one of the largest disparities in death rates between black and white men, which is about 2.5 times higher in black men. This ratio was seen in previous decades before the era of PSA testing as well. Black men tend to be diagnosed at a younger age with more advanced tumors, having a 1.5-fold higher incidence of metastatic disease at presentation. It is suggested that sub-Saharan ancestry may be more relevant than geographic location in a study of African and Caribbean men. Japanese men have the lowest risk and are also known to have a lower level of 5-alpha reductase activity. However, it is unknown whether these differences in incidence among ethnicities are really because of genetic or environmental causes. Next we will look at his family history. Family history confers up to a 2.5-fold increased risk if a man's brother or father has been diagnosed by age 60. If 2 or more first-degree relatives develop prostate cancer, then the risk is increased 7-fold to 8-fold compared to the general population. Younger age at diagnosis in a family member is a higher risk than a family member who is diagnosed later in life. And now let's shift gears to his diet and lifestyle. Diet and lifestyle are also associated with a risk of prostate cancer. Those men having a diet with any of the following have a higher risk of developing prostate cancer. Diet high in saturated fats and red meat and low intake of fruits, vegetables, tomato products, fish, or soy. Vitamin D, calcium, lycopene, zinc, omega-3 fatty acids, alpha-linoleic fatty acids, selenium, vitamin E, statins, and non-steroidal anti-inflammatory medications have been correlated with decreased risk in observational studies, but it is not sure in what way they affect the disease. Several of these agents have been investigated as dietary supplements in prospective trials, but the studies did not show a benefit. Next we will consider genetic syndromes. Germline BRCA2 mutations are associated with a 2-fold to 6-fold increase in the risk of prostate cancer. It is not known exactly how much the BRCA1 mutation affects prostate cancer, although the two are often considered together. Cancers in men with these mutations are more aggressive, occur earlier, and are associated with a significantly reduced survival time. Men with Lynch syndrome, germline mutations in MLH1, MSH2, MSH6, PMS2, or EPCAM, have a 2-fold to 5-fold increase in the risk of prostate cancer. However, these cancers act similarly to those cancers without the mutation, so they are not more aggressive or occur at any earlier age. SJS has the following risk factors for the development of prostate cancer: race and diet. Modifiable risk factors include maintaining his exercise regimen and making some changes to his diet, with less red meat and incorporating fish into his regular diet, as well as more fruits and vegetables. The next question reads, SJS has learned that his 47-year-old brother was just diagnosed with advanced prostate cancer. So my question to you reads, how has SJS's risk changed? Because SJS now has a first-degree relative who has been diagnosed with prostate cancer, especially before the age of 60, his risk has increased substantially, that is 2.5-fold. After SJS's brother's diagnosis, he becomes concerned and makes an appointment with his primary care office to discuss screening. My next question to you reads, should SJS begin routine screening for prostate cancer? In the past 25 years, 5-year survival rates increased from 68.3% to 99.9%, attributed in part to early detection, with a 10-year survival rate of 97.8% and a 15-year rate of 91.4%. There are several guidelines for the screening of prostate cancer, including those of the American Cancer Society, National Comprehensive Cancer Network, abbreviated as NCCN, and the American Urological Association. Historically, men over the age of 50 were encouraged to have a PSA screening yearly. There was a steep rise in the diagnosis of prostate cancer once PSA screening was put into effect in the early 1990s. From less than 100 cases per age-adjusted 100,000 in 1975, and peaking at 240 cases per 100,000 in 1992. At the time of writing it is fairly constant rate of 158 cases per 100,000. However, there is now some controversy among different entities regarding the appropriate recommendations for PSA screening. Prostate cancer is a relatively slow-growing cancer that may not be life-threatening to some patients and potentially would not need treatment. Because it occurs primarily in older men, a number of males might not ever have symptoms of the disease that would cause them to be tested if not for routine screening. The prostate, lung, colorectal, and ovarian, abbreviated as PLCO, screening trial randomized over 76,000 U.S. men to strict annual PSA and digital rectal exam, abbreviated as DRE screening, or to standard practice. It was found that prostate cancer was identified more often in the annual screening group, but that it did not change the rate of fatal disease. However, a European study that randomized over 182,000 men to yearly screening or to no screening found that in the screening group, the relative reduction in risk of death was 21% at a median follow-up of 11 years. To prevent one death from prostate cancer, 1,055 men would need to be screened and 37 cancers would need to be detected. Therefore, it is being recognized that prostate cancer may be overdiagnosed. That refers to overdetection, especially at older ages. Overdiagnosis is typically defined as detecting a disease when it would not otherwise have shortened lifespan or resulted in adverse effects. The United States Preventive Services Task Force analyzed data from several trials and concluded that for every 1,000 men between the ages of 55 and 69 who were screened, 0 to 1 death from prostate cancer would be avoided, and that 110 men would be diagnosed with prostate cancer. However, 100 to 120 men would have a false positive that would result in an unnecessary biopsy. There are risks associated with any potential diagnosis, including risks during biopsy such as infection, bleeding, and dysuria, along with risks associated with unnecessary treatment, which need to be taken into account in the risk-to-benefit ratio of screening. These studies highlight the need for selective screening to avoid overdiagnosis and overtreatment while not compromising long-term survival. Guidelines are consistent in their recommendation that men over the age of 70 to 75 do not need to be screened as they have not been diagnosed with cancer at this time and are more likely to die of unrelated causes before ever having any symptoms in this slow-growing cancer. Guidelines emphasize considering the life expectancy of the patient and not screening those whose expectancy is less than 10 to 15 years. For those at an elevated risk of developing prostate cancer, e.g., family, ethnicity, or other risk factors, screening may begin earlier. However, many of the guidelines are advocating that men should have a discussion with their doctor regarding any risk factors that they have and together decide whether they should undergo screening and at what age to start, depending on their risk factors, comorbidities, and personal preferences. For SJS, because of his elevated risk due to his brother's diagnosis and his ethnicity, as well as his modifiable risk factors, it may be considered prudent to begin screening. However, this should be discussed with his doctor to ensure that he recognizes all of the benefits and risks of screening. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arawa, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 440.